introducing Todd Heniford, one of the most influential and legendary figures in modern hernia surgery. So please, Todd, stage is yours.
Thank you very much, Rod and Ram, of course, and it's great to be in a session with friends. Keith and Hugh I've known for a very, very long time, and look forward to getting to know Dr. Aurora. That's a terrific lecture talking about one of the hottest topics in surgery, not just in hernia repair. But we're going to talk about tonight. We're going to talk about the use of CAT scan and then AI, looking at risk stratification and also predicting complications. And in lecturing with me will be Sully Ayuso. Sully has been in our lab for a year and now is back out in his residency. He's one of our remarkable surgical residents. He just published a paper in JAMA Surgery. And actually has 3 other papers that will be coming out looking at AI and predicting wound-related complications. Here's my disclosures. Why a CT scan? Of course, it's available. It's highly reproducible from one institution to another. It's fairly standard, and essentially most of the patients that come in to see me already have one. The expense, it's relatively inexpensive, and I actually consider it an extension of the physical exam. And we could give an entire talk just on CAT scan and what to look at in a CAT scan and how to use a CAT scan to help drive your care and truly improve your ability to prepare for the operation, prepare your patient for the operation, and then also after surgery, what to look for after surgery. But of course, can it actually predict complications in our patients, and also stratify risk? Of course, all of these types of patients will have had a CAT scan, typically before I actually even see them. Patients like this, with a fistula, easy to see on a CAT scan, but how to get into the abdomen, how to, what intersection of the bowels involved, et cetera, that's pretty easy. Patients like this, whose CAT scan doesn't actually match their operative node, fairly complex operation, supposedly has an intraperitoneal mesh, has a failed external oblique release on the patient's right side, as you can see here. But then as you look down over here, if you can see my arrow down the right lower side, she has tacks outside of her abdominal wall. So again, preparing for this patient, we know that we don't have the full story, and the CAT scan helps put that together. And then also in patients like this, of course, this is a bilateral failed external oblique release with a blowout through the external oblique. And of course, the semilunaris has been lacerated here. One of the things that's important here, as you can see in the CAT scan, the midline is actually still together, and you can see on the operative side over here that the midline is together. But one of the things that does help me with in this patient is talk to the patient about rectus muscle function and abdominal wall function after the operation. So this operation is not going to make the rectus muscles work again. They will never work, but it does help me prepare for the surgery, but also help me prepare the patient for what they'll have left. Other things that you can find from preoperative CAT scans, like the assessment of pain, and then other patient assessments, such as patients with concomitant disease, liver disease, ascites, and even sarcopenia. What have we done to try and use CAT scans to predict outcomes? And this was done by Katie Schlosser and Sean Maloney. These are 2 residents that work with in our lab. And Katie is actually going to be working with Will Cobb in alpha carbon next year in a fellowship in abdominal reconstruction. She published this in Surgical Endoscopy about 15 months ago. But what we looked at was looking at subcutaneous volume, total visceral volume, and hernia volume, and looking at could we predict outcomes. Of course, the need for component separation, hernia volume and intra-abdominal volume played a role. The subcutaneous fat did not. But if you look at fascial closure and operative time, hernia volume played a role in all of these, as did the extra-abdominal volume. But when you look at the complications, hernia volume, the volume of the amount of the intestine and omentum, et cetera, outside the abdomen played a key role in predicting wound complications, readmissions, reoperations, recurrence, and even length of stay. And intra-abdominal volume played some role in that. You can see the p-value is not nearly as strong. We had almost 1,200 patients in this study, but the extra-abdominal volume, again, subcutaneous fat, obesity played a role in wound complications, readmission, and the need for percutaneous drain. How about pulmonary failure? Of course, looking at CAT scans to try and predict pulmonary failure. Our rate of pulmonary failure in these big open abdominal reconstructions is just shy of 7%. And pulmonary failure in our hands is not necessarily intubation, but high flow oxygen, especially those requiring admission to the ICU. Body mass index played a role. Age, I had no idea that diabetes would be so important in patients developing pulmonary failure, and then of course pre-existing lung disease. But again, looking at the CAT scan, the defect area, as the area got larger, 250 square centimeters, when we broke these down into very low risk, medium risk, and higher risk patients, large defects, look at the hernia volume of over 2 liters, and if you skip down to the hernia volume abdominal wall ratio of greater than 50%, these patients reach high risk for pulmonary failure. And how about weight change? Can you predict weight change? And if I can get a patient like this guy to actually lose weight, putting him back together again, removing the 3 meshes that he had in his abdomen, it actually becomes quite a nice operation and much easier. Just weight loss of 5 kilograms makes a huge difference. 11 pounds, you can see the intra-abdominal volume, total visceral volume, and subcutaneous volume. And with all of this, it helps us get the abdomen closed, but if you think back to the slides I just showed, that if you can decrease these volumes, you can decrease complications. Unfortunately for women, women tend to carry their weight all over. So if you divide this between men and women, men lose a lot more fat involving their abdomen than women do. Women do lose weight and do lose volume in their abdomen, but not nearly as effective as men. One of the things that we also learned from this in predicting patients who will actually be more difficult to repair, if you wait to operate on patients, and I'm now, not in favor of watchful waiting for ventral hernias, especially the patients who have long midline hernias. Now, this is part of that paper published in Surgery that Katie had done. If you look at this, is the same patient 14 months later, no change in weight. But if you look at the defect size is substantially larger, and the hernia volume is substantially more. And essentially, this patient is now much more difficult to fix, and you would suppose would carry a higher complication rate. And if you look at the mean change in defect size, just pick 18 months for a midline laparotomy, increase in defect size by 85 square centimeters, and the hernia volume by 550 cubic centimeters, making these actually just a really different animal in trying to repair them. We've tried to try and predict component separations in the past, and this was done by one of our former fellows, Laurel Blair and Sam Ross, who's now one of my partners. It was a rudimentary attempt at this several years ago. Of course, others have tried to look at this. We actually look at the angle from the aorta. Of course, when you see this and you do this mathematically, it does not take the hernia volume into account at all. Here's one by Will Cobb and Alfie Carbonell, where they actually looked at just the width of the rectus muscles and whether someone would need a component separation, a components release or not. But again, it did not include the subcutaneous hernia volume at all in these patients. Could we do better? And so Charbel El-Haj, working with Sully in our lab, started looking at artificial intelligence and deep learning. And of course, the consideration of artificial intelligence and deep learning, can this actually replace some of the what we do as physicians? And this is not a new idea. This was actually first published in all of these quotes actually came from 1970 in the New England Journal of Medicine. And so has this been used before? It has. It's artificial intelligence looking at scans for cancer, and also even more importantly for pathological slides, like an evaluation for breast cancer in biopsy specimens that actually has been used. And what we wanted to do was looking at our previous data, because our previous data actually was just looking at objective data, looking at CAT scan data. In these patients, because our previous data was pretty successful, could we actually use AI and look at just CAT scans and then predict outcomes? And so what these guys did, and Sully will talk about it in a few minutes, but what they did was they took over 350 patients' CAT scans. They took 80% of them and allowed the computer to review these images and gave the answers to the computer. So the computer knew whether the patient was going to have a component separation or not, knew whether the patient was going to develop wound-related complications, and knew whether the patient was going to have pulmonary failure. And then it went through these over and over and over again until it got each test 100% correct. So it looked at 300 CAT scans, and then it did it over 12,000 times until, like, looking at component separation, until it looked at every single CAT scan and got it correct every time. And so it took over 12,000 times for the computer to be able to do that. But what is the computer looking at? We actually don't know. You really don't know if it's looking at intestinal volume, hernia volume, subcutaneous volume, looking at the pulmonary cuts. We just really don't know. And so they published this in JAMA Surgery this summer, and it's gotten a lot of acclaim. But again, 369 patients, 80% of the CAT scans were for training, and then the 20% for the test. And then what we found is that in looking at whether the patient will need a component separation or not, the area under the curve of almost 0.75, which was excellent, really quite good. So then what we did was we actually compared it to surgeons. Surgeons took the same test group and looked at the same test group that the computer did, and master surgeons, 6 master surgeons who perform abdominal wall reconstruction and complex abdominal wall repair. Actually, the computer did substantially better. You can see the area under the curve for the surgeons was 0.64 or 0.65 versus 0.75 for the computer. And can they predict wound complications? And this is the data predicting wound complications in these same patients, these 360 patients, and then predicting pulmonary failure. And I love it when our fellows actually have such substantial wins, when you can see that they actually predicted wound infection in nearly 90% of the patients looking at CAT scan, once you train the computer to look at these CAT scans. But they called this a fail. If the area under the curve was only 0.55, 55% of the time, it effectively predicted patients who would develop pulmonary failure. I consider that a huge win. Of course, these guys, being perfectionists that they are, continue to work on this. And so, for me, looking at where we were to where we are, even if you just look at pulmonary failure, it's substantially improved. And so I'm going to stop here, and Sully's going to take us into the next part of this. And Sully, I will stop, and if you can share your screen now.
Sounds good. Thank you, Dr. Heniford. So I'm going to pick off where Dr. Heniford left off. As he said, predicting wound complication or component separation with an area under the curve of over 0.75 is truly remarkable. But what we wanted to do is improve the ability to predict rare outcomes. An ROC of 0.5 essentially is slightly better than a flip of the coin in being able to discriminate a positive versus a negative outcome. So a few things came to mind as we were developing these models is, could we increase the number of images in our data set for our models to train and accurately predict outcomes? And then secondly, just intuitively, when there are more instances of an outcome, the deep learning models that we develop are better able to train because they have more representations of the data. And then the third thing that we thought of after the first project was, how can we integrate the data that we have at Carolinas Medical Center, which is quite robust, to supplement model performance? And so the aim of our kind of second project of many that we're currently working on is to try to improve the deep learning model performance specifically on outcomes that occur less frequently. So we already had one outcome that we could kind of tamper with, which is the pulmonary failure model. And as Dr. Heniford said, and overall in our data set, it occurs in approximately 7% of patients. Mesh infection occurs in much less than that. And so I think given the fact that that is one of the most devastating outcomes in abdominal wall reconstruction, that was another outcome that we would like to target in terms of outcome prediction. So here's our conventional deep learning model. So the input is a CT scan, so 5mm slices that encompass the entire hernia defect. The model essentially discriminates based on data that is unknown to the user, then extracts features and either puts a patient or a CT scan in a positive or a negative outcome prediction based on the model training and then validation in a separate 20% of the data set. So we reviewed the data science literature, and I think one of the things that was important here is a multidisciplinary collaboration with people that do this much more frequently than we do. And so we partnered with a data scientist to kind of go through the literature and see what was working out there to predict outcomes in other fields for outcomes that occurred, less frequently. Wound complications occur in 20 to 30% of patients that undergo abdominal wall reconstruction. Component separation in our data set at Carolinas Medical Center is quite common as well. So what we came across is two things. One is image augmentation, so artificially creating images that are based on representative kind of CT scans in this case. And the second one is anomaly detection. So training a data set based solely on the positive outcomes. So that would be things like mesh infection and pulmonary failure. And then in the validation set, where we're testing the model, looking and seeing how well that we can discriminate based on features that aren't characteristic of that positive data group. And so here we have data from approximately 500 patients. That is about a 40% increase from our initial paper. And you see here the number of images that we used was approximately 10,000. Mesh infection occurred in 3.7% of this population. That is almost double of the mesh infection rate in our overall group, but this is a representative sample of 500 patients out of nearly 3,000. And then pulmonary failure you see here occurred approximately 5% of the time. But these are just representative CT scan cuts on the left that we use to input into the model. And so when we looked at the outcome prediction of our conventional model that we published in JAMA Surgery for both pulmonary and mesh infection, the model performed okay, is what I think I would say and what most data scientists would say, with an AUC of about 0.6. Generally, we view 0.7 to 0.8 as good, 0.8 to 0.9 as excellent, and then 0.9 and above is kind of out of this world. And so we wanted to compare how our novel model that incorporated both image augmentation and anomaly detection performed in comparison to the initial model for these more rare outcomes. And what you see here is for pulmonary failure and mesh infection, the area under the curve increased by more than 0.1, which is quite remarkable and being able to just distinguish positive from negative outcomes. And so when we look at the accuracy, sensitivity, and specificity, you see that the conventional deep learning model that we have already published on was very accurate in predicting a specific outcome. So the overall number of guesses that the model was making in terms of it was very accurate in being able to distinguish that, but it could not pick up very in a sensitive manner on all of the instances of mesh infection that occurred. And so what you see in the pulmonary failure is the same thing. So our kind of novel model that we developed with image augmentation anomaly detection overall was much stronger because it wasn't compromised by decreased model sensitivity. So what was kind of the deciding factor in terms of strengthening model characteristics? So when we looked at image augmentation alone, so this is generating new instances of an image, but training again on the negative and the positive outcomes, we see that this isn't much better than the original model for pulmonary failure. And that was the exact same when we looked at mesh infection, suggesting that anomaly detection, where you train a data set based on just the positive instances of that specific outcome, and then recognizing images that do not kind of look like those was kind of the driving point for our novel model development being very strong. And so kind of conclusions from this data set, image augmentation anomaly detection, which we term GAN anomaly, which is the term that we're going to use in the paper coming out, was effective in improving model performance for rare outcomes. And that was driven predominantly by anomaly detection rather than image augmentation. Conventional deep learning models were compromised by decreased sensitivity. They could not pick up on these outcomes rarely. And I think, something that Dr. Heniford and I talk about frequently is that we train these models based on our data alone. And we feel very confident about our data set being, up to date and prospectively maintained. So we're training models that we feel we're very confident that they're predicting accurately outcomes, which I think kind of is in part the reason that why we've been able to do this so successfully. And so future direction, here is a paper that was published from a group at Massachusetts General Hospital recently in the Journal of Surgical Research. And I really like this quote, and I feel like this is very applicable when we talk about the use of AI in medicine. It is certainly coming, and it is already here, as much as I think we like to run from things that we don't understand. We're not going to be able to in the long term. And so the application of deep learning is not a revolutionary process, but an evolutionary one. And I think all of these incrementations of what we are kind of putting together at Carolinas Medical Center are going to be important in being able to deliver outcome prediction and risk stratify patients at the bedside. So the next step, or one of the next steps for our group in abdominal wall reconstruction, is saying, hey, do these models that we develop work on CT scans from other institutions? So we know that, we are a large tertiary care referral center. We're getting CT scans from all over the state and all over the country. And so these CT scans, are coming from different scanners, et cetera. But the one thing that I think we have going is that we perform repairs in a very consistent manner. We predominantly use pre-peritoneal approach to repair. We predominantly use large mesh overlap, and seeing if these specific outcomes will be applicable when we get CT scans from other institutions and use the outcomes that were recorded by their data sets. So I think another thing to keep in mind, and is very important, is what we're doing better than what exists. Dr. Heniford had mentioned things that we had done at Carolinas Medical Center in the past. Dr. Carbonell and their group, were predicting the ability to close fascia based on the the rectus muscle versus the width of the defect, and they did that pretty successfully. But are things that we're putting together better than general linear regression? Are they better than things that we put together at our own institution, like the CEDAR app, which predicts wound complications for patients undergoing open abdominal wall reconstruction, or NSQIP, et cetera? And so keeping ourselves honest, I think, is going to be the most important part of this process going forward. And then how can we integrate large scale data? So we have data from approximately 3,000 patients who underwent open abdominal wall reconstruction, being able to tie in factors that we know impact outcomes, such as smoking, diabetes, and predicting wound complications, et cetera. That is kind of what's going forward. We have unfortunately not been able to augment our outcomes much with that to this point, but I think that's in large part given the fact that we hold smokers and diabetics to a strict standard before they get operations. So, at our institution, it is mandatory that patients quit smoking 4 weeks before their operation and have an A1C goal of below 7.2. But being able to integrate data points that we might not know impact outcomes yet is something that is certainly on the horizon for our group. And, this is a field that we're lucky enough to have a bunch of large databases that we can draw on and hopefully collaborate with other partners and other institutions to make models that are going to be quite applicable and beneficial for patient care. And so this is kind of, I think the way I see artificial intelligence and deep learning going is being individualized. This is a figure from a paper that was published in JACS not too long ago, essentially predicting outcomes for patients undergoing emergency general surgery. And I think, being able to go through things algorithmic and having, image-based deep learning model predictions as a part of this, where you say, this is the type of procedure that the patient is having, these are their medications, and then kind of go through an individualized checklist for patients, and then be able to have a risk stratified outcome based on many different factors rather than, just one or two things, is going to be ultimately very strong in terms of influencing what we do for patients. And so I think, just to reiterate, each and every one of these projects is going to be important going forward, and being open-minded, but also being honest with yourself about, what these models mean in terms of their ability to predict outcomes, and how well, we trust the data that we're training these off is very important going forward. Thank you guys for allowing me to present. Thanks to Dr. Heniford for always being open-minded to new ideas.
So I think Romana's got one, but I'm going to ask Todd quickly. So should we stop waiting and just operate if the hernia is going to get bigger, or should we get their weight down? What do you think is more important, getting the 5 kilograms off, or getting in and stopping the hernia doubling in its size?
Well, I mean, I think that there's little question if you operate on smokers, and unless you're going to do this laparoscopically, you're going to be like Hugh and do them laparoscopically or do these robotically. Or patients who have obesity or uncontrolled diabetes, you're going to have problems. And so complications complications in these patients increase our recurrence rate by more than 3 times, between 3 and 5-fold when we're doing them open. And so I press on the patients that it's, instead of saying, go get your life right and then come back, I press on the patients to actually, we need to do this. We need to move this along. And then I, instead of sending them out and maybe seeing them back in 6 months, now see them back in 45 days, and then recheck with them. And so I'm much more on top of them. I'm also much more likely to send them to. So I'm getting a lot of echo back. Send them to for formal bariatrician consultation, or even bariatric surgery more rapidly than I would have in the past. But I hold them to a standard. I'm not going to operate on if you're smoking. You know, hemoglobin A1C of 7.2. You need to lose enough weight that I can get your abdomen closed, and every point of BMI decreases morbidity. And so I hold that kind of seesaw back and forth between that and letting the hernia get larger, and converting these people to a much more difficult operation.
Okay, Romano, I think you had a question.
This for Todd. Are you able to hear me?
Surely.
Yes.
Yes.
Todd, all this unreal computer and artificial intelligence interpretations of images and the data that you feed in, how far are these away from being practically usable for the real world? When do we see another app, and when do we start using these on our own patients? And are there any hurdles along the way?
Well, I think Sully did a good job delineating one of the key factors. One of the key factors in this is surgeons performing the operations differently, and then different subsets of patients. One of the things I think of the advantages that we have here that you mentioned is, you know, the people that I work with, essentially I've trained them, and we've worked together for a long time. We all do preperitoneal mesh choices very equal. We hold patients to a standard. So, you know, within our microcosm, I think they work well. But before we can release these, and before Sully can have his first app, which is the plan is that we'll do this, we have to do a multi-institutional trial. And so the CEDAR app works because, you know, smoking is bad, and obesity is bad, and enterotomy is bad, and all those things are bad. And but the consideration of whether a preoperative CAT scan will yield post-operative outcomes, I think we have to put it through a multi-institutional trial, and that's what we're currently doing. We've signed contracts with folks. I mean, trying to get this through legal is just amazing, you know, to share information, and it should be difficult, let's just say, but once that happens, then the answer is yes. We will. When you're being able to take a CT scan and put it into this app, and then seeing what these possible complications are, I think it will change an awful lot of the way we talk to patients, even in the consent process. If you know you're going to have, let's say you work in a small hospital and this patient has a 60% chance of developing pulmonary failure, you know, perhaps that ought to be done at a tertiary center. Or that they're increasing the wound-related complications, you talk to the patient, and perhaps the patient decides not to have surgery. The consent process will change as well. Resource utilization, where the patients actually have their operations in the consent process.
Thanks.
I think Dr. Hensman has something he'd like to ask. Chris?
Yeah, Todd, thanks for your presentation, and as usual, great insights. My question to you is, you know, in Australia, we are just in the final stages of launching a registry with all of the nuts and bolts of a learning healthcare system that has the power to analyze some of these data points and use artificial intelligence then to predict the kind of things that you're doing. And I wonder whether you could make a comment for that, about that, because I think this is the next step, the nested registry data that can be used to drive options, risk mitigation, and prediction for patients with regard to hernia care.
Maybe I'll pass that to Sully. So Sully has certainly talked about that an awful lot.
Yeah, no, I think that's the goal. Just to kind of reiterate, you know, a couple of things is, one, that, you know, we trust in our own data at Carolinas Medical Center. The outcomes that we have reported for the studies that I alluded to are completely independent of the surgeons that were performing the procedure. So we have a data collection team that really has no stake in the outcomes that we have for our patients. And then we have a team of researchers who kind of work hard to kind of make sense of the data. And so I think that, when you're talking about more large scale data collection, it has to be standardized in how it's actually collected, and that data is pure enough that if you're doing anything that's algorithmic, that you're, kind of feel okay about, the predictions that are being had. Because if you create a data that is actually predicting outcomes that are incorrect, then that's doing a tremendous amount of harm, potentially for, triaging patients to specific centers, et cetera. I think that, the kind of nuts and bolts of, artificial intelligence and stuff, what we're doing is that you also have to kind of read between the lines a lot of times in the models that are being developed here, because unfortunately, a lot of folks are kind of new to this as we are as well. And you want to make sure that the models that have been developed are, kind of among a certain criteria. The data that we reported both in the paper and then what I just, kind of reported is, averaged out over, thousands of iterations. So this is not just kind of a one-off and being able to detect something. So I would say, to kind of answer that question simply, again, just make sure that the data is being reported accurately and consistently.
It's all about Chris, it's all about the accuracy of the data. It's interesting to hear Hugh talk about, like, I put it in the pancreas and I put a trocar in the liver. And I mean, just like when you become a mature surgeon, you're unafraid to say, here are my complications and here's what I've learned from them. When I was young, I tried to hide everything. I didn't want anybody to know about my complications, and it would hurt my feelings. And so, but being accurate data, and you can do some amazing things with accurate data.
So look, we might finish there. Look, I want to thank all the speakers. We've had a great first session that's set the tone for the next two sessions, where we're going to hopefully learn how to mitigate those risks and then finally treat the ones that we can't avoid or happen anyway. I want to thank all the speakers, and I'll